Hi everyone, welcome to our concept map presentation on the topic of community-acquired pneumonia. Here's a concept map we have come up with for this presentation. And as you can see, the main topic is community-acquired pneumonia. So under this main topic, we have 7 subtopics, and they are risk factors, pathophysiology, complications, signs and symptoms, diagnosis testing, medicational management, and clinical management. So we're gonna go through each of these in the following slides. And before we head on to that, I would like to explain how all these subtopics are linked and connected together in one overall concept map. So there are arrows on the concept map, as you can see, and they are labeled with linking words, which will help us understand how these topics are related. And the risk factors, we can see immunocompromised system, age, underlying diseases, and lifestyle factors. And in the lifestyle factors, there are still some more that we can discuss on and how it leads to the increase, whether it's increased exposure to community acquired pneumonia. So in the pathophysiology part, we can see how disease occurs and how it's linked to complications and to signs and symptoms. In the complications itself, you can see there are acute respiratory failure, sepsis, empyema, lung abscess, pleural effusion, and how each presents symptoms. And we can see the diagnosis testing, and diagnosis testing itself has like a small concept map because we need to know how each or different types of bacteria or viruses are detected by different testing methods. And community-acquired pneumonia can be improved and treated by clinical management and medicational management, which we need to consider to improve the health outcomes of the patient and the disease. So, under the medicational management, we can see medicational management is dependent on the severity of the cases, either mild, moderate, or severe. Under the clinical management, we can see clinical strategies, and we can see the considerations we need to pay attention to when we're dealing with patients with community-acquired pneumonia. So this is the community-acquired pneumonia concept map. First of all, we're going to talk about the pathophysiology of community-acquired pneumonia. And before we start that, we need to know what is community-acquired pneumonia. So community-acquired pneumonia is an infection to the lower respiratory tract that includes air sacs, also known as alveoli, and interstitial spaces, which they become inflamed, caused by bacteria, viruses, fungi, etc. Community-acquired pneumonia is transmitted through normal social interactions that occurs within the community settings outside of hospitals or healthcare facilities. And the main pathogen that cause community-acquired pneumonia around the world, regardless of age, is Streptococcus pneumonia. And the pathophysiology of community-acquired pneumonia involves the interaction between the virulent vectors of pathogens and a host defense system. So firstly, the foreign bacteria or viruses will enter into the lungs via inhalation or aspiration of germs from gastric contents or oral secretions from mouth or stomach into the lungs. In a healthy person, microbial pathogens are cleared from the lungs by the body defense mechanisms that include cough reflex, mucociliary escalator, resident immunoglobulin, IgA antibodies, alveoli macrophages, which engulf and kill virulent microorganisms. So when pathogenic bacteria enter into the lungs, they multiply in number rapidly and they attack the lung parenchyma, that is a collection of alveoli, and thus the parenchyma will die via apoptosis. So when that happens, body immune response is activated. That means lymphocytes and neutrophils are activated and they are attracted to infection sites, that is in alveoli, and they will release inflammatory mediators such as cytokinase, prostaglandin, etc. And these inflammatory mediators will cause the inflammation of the parenchyma and vasodilation of the blood vessels to the alveoli. Hence, it will cause vascular permeability to increase. Thus, more fluid will leak out, and there will be a fluid buildup in the alveoli, causing pulmonary edema. So, the fluid accumulation in the alveoli, the neutrophils and the lymphocytes, they disturb the gaseous exchange in the lungs and causing pulmonary hypoxia, that is, decrease in oxygen in the lungs. The ventilation perfusion imbalance occurs when poor ventilated or non-ventilated, and because of the fluid-filled alveoli does not allow enough oxygen from alveoli to diffuse into the normally perfused capillary blood. Therefore, the ventilation to perfusion is not much. Pulmonary shunts occur because of that, and because then the arterial blood oxygen will decrease, causing arterial hypoxemia, and the whole body oxygen consumption will still be increased. In normal people, low oxygen in the lungs is addressed by the vasoconstriction of blood capillaries and redirections to the better ventilated alveoli than non-ventilated alveoli. But this is not happening in community-acquired pneumonia patients because of the prostaglandins production, the vasodilators that we discussed above.
So some of the risk factors that is associated with community-acquired pneumonia would include having an immunocompromised system. So an immunocompromised system through causes such as immunodeficiencies, human immunodeficiency virus, also known as HIV, chronic obstructive pulmonary disease, also known as COPD, and immunosuppressive therapy for treatment such as cancer treatment, can all foster a negative alteration in the immune system, impacting the way it functions as well as its effectiveness, which in combination leads to the immune system's vulnerability to infections, especially to those viruses and bacteria that causes community-acquired pneumonia. Age is also known as a risk factor, as individuals that are aged 65 and over acquire contact with community-acquired pneumonia more often than younger patients below the age range, with a study indicating that 90% of deaths due to community-acquired pneumonia predominantly occurs in this age range. Furthermore, having underlying diseases is also a risk factor. There are various underlying comorbidities that are determined to be in conjunction with patients diagnosed with community-acquired pneumonia, and some more often than others causes higher incidence rates. The frequencies of comorbidities in patients diagnosed with community-acquired pneumonia aged 65 years old is higher than those below the age range, and in 39 studies, some of these comorbidities include metabolic diseases, chronic heart disease, renal disease, respiratory disease, CNS diseases, diabetes, neuroleptic diseases, and prior invasive pneumococcal diseases. And finally, a risk factor that is associated with causing community-acquired pneumonia would be an individual's lifestyle factors. So an individual's lifestyle approach may be a risk factor linked to an increased likelihood of becoming diagnosed through aspects such as coming into regular contact with children, which raises their exposure to community-acquired pneumonia, as children have an increased Streptococcus pneumoniae carriage, potentially increasing that individual's risk and exposure to bacteria that mainly causes community-acquired pneumonia. Furthermore, smoking causes damage to the respiratory epithelium, resulting in the low clearance of bacteria, promoting the occurrence of lung infections or community-acquired pneumonia. Another factor is an increased alcohol consumption, which could cause a defect in innate and adaptive immunity, resulting in a weakened immune function. Finally, being underweight as a consequence from age or undernutrition could cause an increase in risk to community-acquired pneumonia due to weakened immune functions. When diagnosing community-acquired pneumonia, collecting sputum samples of the patient is crucial in determining the presence of various germs that can potentially cause it. These germs include viruses of which are influenza A and B, adenovirus, parainfluenza, and respiratory syncytial virus. Atypical bacteria such as Chlamydia pneumoniae, Mycoplasma pneumoniae, and Legionella bacteria, and typical bacteria such as Streptococcus pneumoniae, Maricela catarrhalis, Haemophilus influenzae, and Staphylococcus aureus. A urinary antigen test is also conducted, which is a practical test that requires the collection of a urine sample for its analysis and the detection of Legionella bacteria that is responsible for causing community-acquired pneumonia. As this test overall has a low sensitivity towards the bacteria, a negative result doesn't always confirm its absence. Blood tests and cultures are also to be taken when diagnosing community-acquired pneumonia for a suspected increase in leukocyte count caused by the immune system fighting the presence of germs from within the lungs, and the detection of Streptococcus pneumoniae, a typical bacteria visible in blood cultures causing community-acquired pneumonia. A polymerase chain reaction is also conducted, and briefly, it is a rapid diagnostic test in the detection of viruses and Mycoplasma pneumonia. A physical assessment is also conducted and is a huge part of the diagnosis of community-acquired pneumonia and is essential in determining the ongoing manifestations that CAP may have produced in an individual system, such as alterations in consciousness, temperatures of above 38 representing a fever, blood pressure below 90 systolic over 60 systolic, chest pain, persistent dry cough, and some common signs and symptoms. But an increase in sputum production is the most prominent manifestation that results in an increased work of breathing that contributes to fatigue and decreased oxygen saturations of below 90 that triggers an increased respiratory rate as observable as above 30. When a chest x-ray is also conducted, and when examining a chest x-ray, the features that clinicians need to observe for when determining community-acquired pneumonia as its diagnosis are the presence of lobar consolidations and infiltrates, inflammation of the lungs, and signs of pleural effusion and multilobar disease, which are all influential in causing abnormalities in respiratory assessment results. A respiratory assessment is also fundamental in the diagnosis of community-acquired pneumonia. Patients with community-acquired pneumonia can be assessed for respiratory alterations such as crackles or rales when auscultating the lungs, egophony, and a change in bronchial breath sounds or tactile thermometers. Furthermore, the presence of asymmetric increase in lung opacification, silhouette sign, increased opacity, and increased attenuation of cardiac shadows are also some signs of community-acquired pneumonia.
When managing community-acquired pneumonia in the clinical setting, the CORB criteria can be used to determine the severity. This includes confusion, whether the patient shows signs and symptoms of being confused, oxygenation as less than 90% saturation, respiratory rate as more than 30 breaths per minute, and blood pressure as hypotensive. The clinical management of the patient is variant depending on the individual. Elders and infants are far more vulnerable to community-acquired pneumonia, which means that they are often admitted to hospital regardless of the severity. Whereas mild cases in teens and adults can be treated at home based on instruction from their doctor and the prescription of antibiotics. Clinical strategies from health professionals includes providing adequate fluids, orally or intravenously, which depends on the severity and condition of the patient, as those with severe cases will often need IV fluids. the administration of antibiotics, again, whether this be orally or intravenously, and ensuring that the patient receives sufficient rest. When approaching the patient for the first time, it is important to implement droplet additional infection control precautions until the influenza swab is taken and tested. In addition, a sputum culture should also be undertaken, as this will detect whether there is a pathogenic bacteria in the patient, which would indicate pneumonia or infectious respiratory tract infection. Testing such as serum testing for mycoplasma and urine Legionella testing should additionally be undertaken for further diagnostic confirmation of community-acquired pneumonia. The management of community-acquired pneumonia through medication is often completely dependent on the severity of the case. Mild, moderate, and severe cases of community-acquired pneumonia all use different drug combinations to treat the patient. In mild cases of community-acquired pneumonia, the healthcare team's first response is often to administer an oral dose of 1 gram amoxicillin 3 times a day. This antibiotic dose will typically continue for 5 to 7 days, depending on instruction from the doctor based on the signs and symptoms of the patient. In a moderate case of community-acquired pneumonia, which consists of 1 CORB criteria, the first response is often to administer IV benzyl penicillin of 1,200 milligrams 4 times a day for typically 7 days. This dose is to be administered alongside doxycycline 100 milligrams oral 2 times a day, or clarithromycin 500 milligrams oral 2 times a day. Severe cases of community-acquired pneumonia, which present with more than 2 CORB criteria, or the patient is admitted to ICU, the patient will often be prescribed a number of medicative treatments. This includes benzyl penicillin IV dose of 1,200 milligrams for every 4 hours, gentamicin IV dose, and the addition of azithromycin 500 milligram dose given as an IV or oral.
Common signs and symptoms of pneumonia include cough, which may produce green, yellow, or rusty sputum. Rusty sputum is due to blood getting included in the sputum. Fevers and chills, chest pains, shortness of breath, hypoxia, abnormal breathing sounds, and tachycardia. For people with weaker immune systems, such as infants or the elders, may show other symptoms such as confusion or cognitive decline, hypothermia, fatigue, and headaches. One of the most common complications of pneumonia is acute respiratory failure. This is caused by fluid building up in the air sacs of the lungs. As the fluid builds up, it interferes with the oxygen exchange, meaning the lung cannot release oxygen into the blood, and as a result, the organs cannot get oxygen-rich blood, which causes them to dysfunction, which is commonly known as hypoxia. It is one of the leading causes of death in severe pneumonia. Other complications include pleural effusion, which is caused by pneumonia as fluid builds up between the chest cavity and the lung walls. And because of this excessive fluid, it exerts pressure in the lungs, causing abnormal breathing movements. Lung abscess is caused by bacterial infections, and the infection causes damage to the lung tissues, resulting in necrosis of tissues. And as these necrotic debris forms cavity filled with pus. Emphysema is another condition where pus forming in the pleural cavity, which is cavity between the lungs and the chest. Sepsis, it's not very common, but still very severe complications, and it's normally known as blood poisoning. It's a complication caused by immune system reacting to an infection. Severe sepsis may cause organ dysfunctions, drop in blood pressure, causing heart failure and stroke, which is known as septic shock. Elders and younger children who have weaker immune system are more vulnerable. The complication still remains difficult to control, and as a result, it is causing high mortality rate. The information we have provided in this presentation have been based on reliable sources, and I hope we have gave you a little bit of understanding of pneumonia. And thank you for listening to our presentation.